Once again, if you have questions or issues or examples or anything on your mind, interrupt. The situation with GI symptoms like this, nausea, vomiting, diarrhea, abdominal pain, very much similar to what we already spoke about with breathing problems, in that the complaints are common, the serious issues are relatively rare. Most of these common problems can be managed at the health station, but your job and our job in the primary care setting is to weed out the potentially catastrophic ones that have to be dealt with at the emergency department from what can be done in the health station. These complaints are common because they're like breathing problems, a lot of them associated with viral illnesses, gastroenteritis, diarrhea, food poisoning. They come in waves with the viruses, so we see a lot of them in the late spring and summer. They're sometimes caused by food and waterborne illnesses. That's less in this country than other places. They're usually benign. Usually it's very simple management by the primary care doctor, symptomatic treatment as we spoke of before, but they can be life-threatening in the two high-risk age groups, the elderly, and I am embarrassed when people define that as over 65, but I guess it is still over 65, and in infants. Diarrhea and dehydration, one of the most common causes of infant death in the developing world. Dr. Fine dug up these statistics which boggled my mind, that these diarrhea kills 2,200 kids every day, 800,000 child deaths a year, second most common death in children under 5. Nausea, we're going to separate out nausea, vomiting, and diarrhea from abdominal pain. The causes of the former, the symptoms, nausea, vomiting, diarrhea, usually it's a viral illness or some food or waterborne problem. The top 5 you can see are medical, usually fairly simple office management problems. The middle 3, cholecystitis, gallbladder disease, intestinal obstruction, a blockage, or appendicitis, those are surgical issues and obviously require a hospital. And the bottom 5 are things that aren't related primarily, aren't caused primarily by the GI tract. So we've got nausea, vomiting, diarrhea being caused by things that have nothing to do with an actual GI cause. Drug reactions, heart attack will cause vomiting, chemical toxins, other poisons, chemotherapy, other poisons, and migraine, basically a neurologic or vascular issue that causes nausea, vomiting. So we've got all of these different, all over the board causes, and if you can, in the field, can discriminate, you can, it's then becomes pretty easy to say this goes to the health station, this goes to the ED. If you can't discriminate, what happens? ED. That's right. Yeah. If there's a question, that's the place to get it sorted out. Most of it, again, reiterate over and over again. The more we say it, hopefully the more you get it. It's benign and self-limited, and we can take care of it with simple hydration. Sometimes we use some medications to stop diarrhea or stop vomiting. Symptomatic treatment. Switch over to abdominal pain. My list, I'm not sure if it's the same as your list, but my list lists the top 3 as not only the most common, but the most treatable, the most simple things that we deal with in the primary care setting. So if we look at those as both the most common things and the most primary care amenable things, gastritis and ulcer, that's an acid-related problem. Stop the acid, cure the problem. Second one, irritable bowel syndrome, all over the place. People with cramps, diarrhea, sometimes nausea. And those people are really hard to treat, but they're not going to die from their illness. So you don't have to, those people are very readily referable to the primary care doctor. Much better dealt with in primary care because they need to be seen over and over and over again by the same person, and ED is just not equipped to deal with this. And the non-specific stuff, the gas, the cramps, the stress-related GI stuff. And that's all better dealt with by the primary care person if it's available. You get further down the list and you get to the bad stuff that we need to have in the ED or the hospital: appendicitis, diverticulitis, ectopic pregnancy. Inflammatory bowel disease is a tough one because it's a long-term chronic illness that the ED doesn't do much for and really needs a specialist management. Intestinal obstruction needs the surgeon. Hepatitis is a problem that needs an urgent diagnosis sometimes, and the pelvic inflammatory disease, abdominal aortic aneurysm. Other kinds of abdominal pain that you guys run into that should be on that list? Do you think of anything else? I didn't add anything on there, but I'm sure there's a bunch of rare, if you look at the differential diagnosis in your textbooks, you've got another 30 things on there that are so rare that we didn't make the cut. %90 are benign, take care of in the primary care setting. 10% more serious, requiring other than symptomatic treatment. When you get on the phone and call over to the health station and say, I got this patient that I think you guys have seen in the past and want to see this time, it's important that you have practice telling them what you got. This is something that we ended up getting hammered at as third-year medical students, was telling the resident what you got in 30 seconds or less, so that the resident knows whether he has to come see the patient, whether you need to call the surgeon, what you have to do. So it's, I have a 65-year-old man, woman with abdominal pain for 7 days, localized to the right upper quadrant, with vomiting, no diarrhea, and then vital signs. Temperature is 102, blah, blah, blah. If you can practice presenting those patients in that kind of a way, that's going to really facilitate how this process works, because the doc's going to be happy. You're going to get relatively quick feedback as to what to do. He doesn't then have to, she doesn't have to ask you the next 10 questions so that this telephone conversation lasts 3 times longer than it should. So practicing that art of presentation is going to make this process work really well. The 3 questions: assessing nausea, vomiting, diarrhea. Is the patient hemodynamically stable? How do you assess that? Louder? Vital signs, yeah, right. Blood pressure. If they're hypotensive, that's not coming to the health station. You know that, and the history will help with that too. If there's if they have GI bleeding, they're not a candidate for the health station. If they're in shock, that's the hemodynamic stable. Are they hydrated? How do you assess hydration? Do you do that in the field? Turgor, yeah. Yeah. You, do they tent when you pinch them? What's that?
I'm sorry, I was making fun of my colleague.
Okay. Is there surgical disease? Do you push on the bellies, or do you do any kind of a physical exam? You do. Excellent. Because what's rebound?
Press on the right and pain on the right. The injuries on the left, you press on the right and experience pain on the right.
No, that would more be referred if it's.
When you let go.
There it is. When you let go, it hurts as much or more than when you're pushing in.
That's usually an ER thing, right, when you get that?
Yes, exactly. Is there surgical disease? If we're talking surgical disease, that's the assessment, one of the assessments for surgical disease is the rebound. That's an indicator of peritoneal inflammation. And if you've got peritoneal inflammation, that's going to be likely a surgical problem. That needs the rebound is the assessment for peritoneal inflammation, and that's an indicator that they need to be in the ED. And once again, the GI bleeding. If they have any sign of GI bleeding, if there's bloody stools, there's bloody vomit, off they go. Abdominal pain, once again, the same kinds of things. Is there rebound? Is there an abdominal aortic aneurysm? How would you know that? That's a rare disaster that when you miss it, it's a catastrophe. If the pain has a tearing consistency, is one of the things that people tell you. I've never seen anybody tell me that, but it's in all the books. And obviously, hypotension means that now you've got a rupture problem on your hands, which is even worse. But trying to pick up the abdominal aneurysm before it ruptures is that's the sine qua non of diagnostic brilliance. But the thing that's talked about in the literature is the abdominal. Once again, with the abdominal exam, if you put pressure in the midline and you feel a pulsatile mass, you feel something that's going like that, that's a possible abdominal aortic aneurysm. That obviously goes right to the ED. And is there a Murphy sign? What's a Murphy sign? No, not ascites. Murphy sign is the gallbladder exam. Is that pressure just under the right ribs, and that elicits pain. That's the indicator that your gallbladder is inflamed, and that should be assessed in the emergency room for whether or not you need immediate surgery. I think there's a question 4, but it's very argumentative, really. The fourth question assessing all of these issues is there fever? Now, fever is not always an indication that you need fever. Fever is like that O2 sat between 90 and 96 is, maybe it needs to go, maybe you can take it to the health station. Fever is a real problem with nausea, vomiting, abdominal pain, and nausea, vomiting, diarrhea, and abdominal pain. Why? Because a lot of them are viral. And so they may have fever, and they may be perfectly appropriate candidate for the health station. And your job is going to be, the temp's 101, could have appendicitis, could have cholecystitis, could have some infection, a bacterial infection in the gut, but this could be viral. So where do you go from there? Well, we're back to that primary care gestalt again. Sick, not sick. The guy with the fever who's otherwise got stable vital signs and who doesn't have these other worrisome things on their exam or assessment or history, no bleeding, that's a worthwhile call to the guy at the health station, because we see these people, we see these conditions all the time. 90% of the time, they're benign and are managed quite comfortably in the health station, and a whole lot less costly. Here's the caveat that we talked about a little bit in respiratory, but it's even more important in GI disease, is that you can't rely on the usual signs and symptoms with people over 65, because they don't respond 100% the way healthy young people respond. Why is that? Why do we not? Why can't we rely on the old guy spiking the fever with if he's got a gallbladder attack or appendicitis? Why can't we rely on them having that rebound? You can't rely on the exam. You can't rely on the temperature. What is it about us old guys that makes us such a problem for you people who are doing your assessments? Tolerance to pain is interesting, and some people are actually worse. You see old people who will grimace when you barely touch them, but others just don't even react to anything. I'm not thinking about that as much as the general across the board issue with old folks. They're old, but they don't mount the appropriate inflammatory response that you young guys do. Young people, when they get sick, release all these inflammatory mediators that push your temperature up, that cause white cells to rush to the site of the abnormalities and make everything hurt appropriately when you push. And old people are sluggish when they move. They're sluggish in their inflammatory response. And that's why the stuff that you rely on with younger people don't always apply in people of 65, so we're much more
Lean back, not sluggish.
I love it. Thank you.
We're not worried about all that.
I do appreciate what do they call it? A better way of terminating, the better terminology for that. Less pejorative. The physical examination is unreliable if it doesn't show you. If you get your Murphy's sign or your rebound, it's valid. Rely on it. If it's negative, can't say he's a health station. His belly's benign, take him to the health station. Maybe not. If there's the least bit of worry about the elderly person, he's an ED candidate. And the lab studies, even in the ED, they have issues with old people because they may not develop a high white count with appendicitis or cholecystitis or diverticulitis. So sometimes even the lab studies can be deceiving in the old folks. What do we do with it? Nausea, vomiting, and diarrhea. We don't do anything in terms of prescriptions necessarily, because they usually get better. The most important thing with nausea, vomiting, diarrhea, in terms of is number 3, hydration. You got to get them. You got to get fluids into them. If you get a patient, if you're in the home or out in the field with a patient who cannot eat, cannot swallow liquids, we're sort of in a situation where you may as well not bring them to the primary care station, because we're not going to be able to treat them. If we can't hydrate them, we can't treat them. They're going to need IVs. Now, some places, and I'm embarrassed by my ignorance about this at the health station, but some places will have the ability to put an IV in and run a liter of fluid. So if somebody's not terribly sick but still says they can't swallow anything without vomiting, certain outpatient facilities will treat them with IV fluids. So that's a possibility that we need to clarify as we go ahead, because if they're otherwise not sick but not swallowing, that's going to be an issue as to whether they can be managed at the health station or whether they do have to go to the ED. And notice that it's not the nausea, vomiting, and diarrhea that kills kids, it's the dehydration that kills kids. So we put them on clear liquids, have them push fluids, monitor urine output, go to the ED if there is worsening fever, if they can't drink, or if they're getting worse. And we tell them to avoid milk products for 5 days. What's milk products all about? No idea. Lactose intolerance develops with diarrhea. When the milk is absorbed in the lower part of the intestine with an enzyme called lactase, and when when patients get diarrhea, specifically, not so much the nausea vomiting end, but when anybody has diarrhea, they can flush a lot of that lactase out of the system, and they will look like a lactose intolerant person for a few days afterwards while the gut is developing more of that enzyme. So we say, look, stay away from milk because that might help your diarrhea get better faster. How do we deal with abdominal pain? Number one, rule out the surgical process, and we've talked about those issues. Then try to find a cause and manage it. Other than gastritis, which is often recognized by the location of the pain, the people have this epigastric pain right below the sternum. They have a quality of pain that's burning. It often radiates up, heartburn radiates up under the sternum, esophageal, and it usually responds relatively quickly either to antacids or to the Zantacs and the Prilosec of the world. So those are relatively easy to treat. If it's not gastritis and it's not surgical, then it becomes complicated, but the process of evaluation is extended. It's not something that we usually get satisfaction in the emergency room. The emergency room is very good for evaluating the surgical causes we talked about, not terribly helpful for the non-surgical, long, chronic abdominal pains. And we get to the red flag page, which is the key thing. Any of these things will be on your list. This goes to the ED. Hypotension, GI bleeding, rebound, or someone who can't walk because of their abdominal pain. And the original slide said age over 65. I think it's just as important to understand that nausea, vomiting, and diarrhea in an infant, we need to be more likely to move them to the ED for evaluation than in the health station, because some of those patients are going to need what's called a septic workup, because sometimes bad infections will present in neonates with no fever and just doesn't want to eat, throws up, diarrhea. And you can't tell the difference between a simple little gastroenteritis, a little virus that's not going to be a problem as long as you hydrate them, and some rare oddball catastrophe in a newborn. So you're absolutely right to get those to the ED without a call. And I think that the question is, what's the cutoff? And everybody's got a different cutoff. I mean, I put 30 days on here. Some people say 3 months. Some people say 6 months. It depends on the system, what people feel comfortable dealing with. Most of your people at the health station, especially the pediatricians, are going to be perfectly comfortable taking care of a 2 or 3 month old with some vomiting and diarrhea, because they do it all the time. That's going to be a matter of negotiation, I'm sure, within the system, is who you just automatically take to the ED and who you call and say, can I bring this kid over? So here we are at nausea, vomiting, diarrhea are common, and as well as abdominal pain. Most of it is benign and self-limited, as long as the patient's hydrated. And we keep coming back to this, that a lot of kids in the developing world die from dehydration. The relevance of that to you guys is you may see a 2-year-old who's got diarrhea, and you go in the room and you think, why did you call me for this? You know, I'm like, this kid is running around, he's fine, he's in the bathroom every hour or two with diarrhea, drinking up a storm, vital signs perfect. What's the big deal? And the big deal is that mom came from a place where kids died from this all the time. And so this thing triggers a panic concept in their heads because they've seen kids die from this illness, even though her kid looks fine. So I think that's one of there can be a real disconnect when you're in a in a room, and it happens at the health center. You see these mothers and you wonder, what is she so worked up about? And the kid's been, dumping watery stuff for a couple of days. So what? That's the reason, I think. And it just puts things together for you. Some abdominal pain requires urgent surgical intervention, and that's what we have the red flags for. Most of it can be well evaluated in the primary care setting. So I got getting through that in half the time. What questions about nausea, vomiting, diarrhea, abdominal pain, or the health system of New Zealand, or anything else? The New Zealand system was particularly interesting with respect to not just what EMTs were doing there, but the whole accident system in New Zealand was radically different. The insurance system was different because the government paid for all accident care. So if you fell and broke something, you were transferred from whatever insurance you might have to the ACC insurance, the accident coverage care insurance, which took care of everything. What that did was it took all of the secondary gain out of being disabled or having a misfortunate event off the table, and it took a lot of the legal issues off the table, because everything that you needed if you had an accident is taken care of by your insurance. No, we don't have to sue anybody. We don't have to sue McDonald's because you slipped on the floor. McDonald's, you're getting your care taken care of. It was such a sane process that it just boggled my mind. One of our locums there, an American guy from, where was he from? Alaska, I think. I think he was from Anchorage, who was an orthopedic surgeon, came to the hospital. It was an hour away from us, and within a month he was off on some weekend jaunt, and he fell on a dock, through a hole on a dock when he was out getting on a boat, and landed so hard that he broke his heel. He had a fractured calcaneus. Now, you can't walk on a fractured calcaneus. He was put on non-weight bearing for, I think, 3 months. He couldn't work, and all covered. Even though he's an American guy temporarily practicing in New Zealand, all his medical care is covered. He's just free and clear, no worries, which was a New Zealand expression. So there are ways to do healthcare right that have been done in other parts of the world that we don't have the political will to do. But this little thing, this little experiment that you were involved in here, is part of the way to do healthcare a little bit more sensibly and economically than it's being done now. And I just think it's brilliant. So, any other questions? Questions about abdominal pain?
Well, not abdominal pain. I have a question in general.
Yep.
Outside of educating us, is there any effort to educate our customers as to what's an emergency and what's not an emergency in this experiment?
I was told by Dr. Fine that they have a grant for public service announcements to be broadcast, radio, TV, and stuff, to try to get people more oriented to getting what they should take to their doctor as opposed to what they should take to other facilities, how to make those judgments. So I think there is an effort. I'm not sure how it's going to be done or what it's going to be, but ask him when he's here, because I know that there's something getting started. Oh,
We actually felt an RFP for a charitable communication strategy. So we felt the ability to address these particular issues that we're having in regards to breast. We still, because of this, we're still out, we're still waiting. We're working closely with some communication strategists to assist us in the process.
I think Dr. Fine touched on the treatment yesterday.
I wasn't
right to cases? You guys got cases, is it better than mine? Nausea, vomiting, abdominal pain, anything else? Or we can start playing with mine. There was one other little item I wanted to mention to you, which is not official because it's not evidence-based, and Dr. Fine would hit me over the head if I did this. A surgeon that I knew had what he called the golden pearl of vomiting. You see somebody with vomiting and abdominal pain, the sequence may be significant. He said, pain first, followed by vomiting. Think surgical. Vomiting, nausea and vomiting first, followed by pain, that's a health station problem, probably. That's a primary care medical issue. It was just another way to help sort out things. Sick, not sick, pain first, vomiting second, vomiting first, pain second. Little pearls. Where am I here? Slides. So this is my first case of nausea, vomiting, abdominal pain, number 7. And that's your number 14. Is that big enough to read out there, or can I mess with it?
13-year-old female with 1 day of diarrhea, nausea, vomiting, who was on a school trip. 13-year-old female with 1 day of nausea, vomiting, and abdominal pain. Her periods are irregular, but her last period was 2 months ago. She has an 18-year-old boyfriend who called 911 because he was annoyed she was getting sick on him. Alert, pleasant 13-year-old laying in bed with her knees drawn up to her chest, looking frightened. Temp 100.2, pulse 110, BP 96 over 56, solution sat 99.
She's 13 and an 18-year-old boyfriend.
Yeah.
She's going to the emergency room, he's going to jail.
You know where she's going, yeah. I mean, everybody's, would there be any argument about taking her to the ED? Nope. Tell me if you were gonna put your hands on her belly, where is she hurting?
Is there a parent on scene?
What's that?
Is there a parent on scene?
You want to,
She got an 18-year-old boyfriend.
yeah, I guess that, yeah, I don't know if that's
The lower quadrant? The lower quadrant?
the lower abdomen. All right, good. More on one side than the other, more in the middle? Where do you think? Left. Middle. Right.
What are we looking for?
What are we looking for? There, all right. Why is it important that she be transported now? What do you think she got? What is it? Ectopic pregnancy?
Chief said it.
STD.
How does an STD connect to this kind of a pain?
Not sure if it sounded funny.
Yeah, just the whole situation I would have to review and go, something's not right.
Something's not right. Yeah, I think that's crucial because that's the two things that you're weighing. The STD connection is to a specific illness that causes this syndrome, and that's pelvic inflammatory disease. The STD gets up into the tubes and causes inflammation of the fallopian tubes, and that creates something that could look just like an ectopic pregnancy. So either one of those is a possible diagnosis here, and you can't tell by looking at this kid, but they both need to be in the ED because one's an immediate surgical condition and the other one is a probable IV antibiotic situation, and telling the difference is crucial to getting it right and avoiding a catastrophe. So the PID is often mid abdominal pain. The ectopic pregnancy may be one side or the other, could be right or left. And the fallopian tube inflammation could be right or left. So you really can't even tell by the exam. But the important thing is it's lower abdominal pain. It's not a gallbladder. It's not an ulcer up here. This is going to be lower abdominal pain, lower abdominal exam abnormality. What's the most significant long-term consequence of this condition? He obviously felt that this was specific to one or the other, ectopic pregnancy or PID. I don't think you could tell the difference from the history, but even if we do it right, what can happen with PID, pelvic inflammatory disease? Not cervical cancer. The cervical cancer caused by the infections, certain infections, but specifically this inflammatory disease of the fallopian tubes.
Causes scarring.
Scarring, which leads to sterility, somebody said, yeah. Infertility. So that's the most significant long-term consequence of this condition, of if it's pelvic inflammatory disease. With the ectopic pregnancy, if you catch it early and you do the appropriate surgery, you hopefully will preserve fertility. Let's see, I gotta go down. The next one, I think, is the next one. Which you have. Somebody got a 75-year-old male up? Number 15.
75-year-old male on Chestnut Street with abdominal pain, some diarrhea and some vomiting of 2 weeks duration. He avoids doctors and hospitals like the plague. Daughter called in frustration when he stopped eating and just keeps refusing to go to the doctor. Because you have come, he'll go to the neighborhood health station down the street, but he wouldn't be caught dead in the hospital ED. And if it's okay with you, he'd rather wait until next week, and if the pain is still there, he'll go to the neighborhood health station then.
And then, what are you going to do with this guy?
Alrighty, sir.
Sign here.
Sign this.
He's America, you don't wanna go, you don't go.
But you're going to try to convince him, aren't you? Because he doesn't belong at the neighborhood health station. Because of what risk factors?
He's too old.
He's too old, right.
We're gonna take him to the ER and tell him it's the neighborhood health station. He won't know the difference.
Excellent.
Stop eating, that's why.
Yeah, there's red flags all over the place. He won't eat. He's too old. He's had symptoms for 2 weeks. This is just a bad collection of symptoms, and he needs to get it. He needs to get checked out to make sure he's not dehydrated. We don't even have vital signs on him. He may be dehydrated. We might not find the cause of his abdominal pain in the ED. This might be a futile visit because he may have some colitis or something that's going to get better over time, or something that symptomatic medicine will help with. But you can't take that risk with this guy because he's such a high-risk character. What usual clinician processes aren't useful in discovering the cause of the pain? The stuff that's not listed on here is vital signs, right? Because we know he may not have a fever even though he has an intestinal infection. Even doing lab work might not tell you until you actually did imaging, which we can't do in the health station.
Clinic's right across the street.
What do you think he has? Guesses as to what his diagnosis is? "75-year-old guy stops eating, vomiting, diarrhea." Could have colon cancer, right? Could have an obstruction, a partial obstruction. Yeah, bowel obstruction due to anything, volvulus, colon cancer, sure. Next one is the next one, number 16. Isn't it 16? Yeah.
60.
7-day-old with diarrhea, 39-week product of a normal pregnancy and delivery to a married, non-smoking, Spanish-speaking mother with 2 children, 2 and 5, 2 other children. Mother called 911 because the diarrhea just wouldn't stop. Temp of 100.2, pulse of 120, respirations 30.
Yeah. Where is he going? ED. Because he's 7 days old? Temp? This may be a perfectly benign condition, but you can't take the chance. You have to have him assessed, and you need to monitor him for a period of time if he doesn't have any other signs of severe illness when you examine him. Is the pulse abnormal?
No.
Not in a 7-day-old, right? Good. You know, some people, they look at that pulse 120. Whoa, no, in a 7-day-old, that's okay. Good, that's excellent. How dangerous is this condition? We don't know, because we don't know what's going on, and so it's dangerous enough because of his age, potentially dangerous, that you have to get it assessed. Why is the mother so frightened?
Because 2,200 kids died last year.
Yesterday.
Yeah, yesterday, you're right.
Yeah. Good. That's exactly.
Developing countries.
Yep. Where she comes from, this is bad news. So the next one is 17.
We don't have a 17.
Don't have a 17.
I don't have one.
Oh, mine had a
Oh, yeah, we
17.
do, yeah. 9-year-olds.
Yep, that's the one. Want to read that one out?
9-year-old male with anorexia, abdominal pain, nausea, vomiting of 1 day's duration. Father called 911 because the child refused to walk to the car, and the father is angry because the child disobeyed. Temp 101, pulse 104, BP 90/60, O2 sat 98%, lungs are clear, heart rate triple R. The child initially refuses to come with you and says he will go to the doctor in the morning if he's not better. He does stand and walk when you encourage him to seek treatment now, but appears to limp and walks a little bent over.
Bent over, should have been, yeah. Typo.
What's triple R for the heart?
Regular rate and rhythm. Regular rate, rhythm, yeah. The ill-advised abbreviation. So let's play the game. You decide that he doesn't look too sick. Let's call the doc at the health station. And I'm on the other end of the phone. I pick up the phone. Hello, what do you got? Present this case to the guy in 30 seconds or less. Who wants to do that? Anybody to pick that up? What's that?
That's a good presentation. That's something we probably get from you. A 9-year-old male with a 1-day duration of nausea, pain, nausea, abdominal pain, and failure to eat. Vitals are temperature of 101, pulse of 104, BP's 90/60, pulse ox at 98. Lungs are clear, heart's regular. Heart's regular. Patient showing weakness when walking.
All right, good. Yeah, that'll do it. That's exactly what we need. Perfect.
You guys don't want
And
to
you'll
stay,
say,
right?
Huh?
and you'll say what to that?
I'm gonna say, what do you mean weak when he walks?
I mean, his father's pissed off, he's
He's got a
bent
limp too.
over.
He's got a limp. He's got a limp and he's bending over a little bit, cradling.
Then I'm gonna say, take him to the ED. Because he has diagnosis? Yeah. Who gave me appendix? This kid's got appendicitis. Until The ED guy says he doesn't. Because he's got a lower abdominal pain. Now, you could poke on his right lower quadrant and verify the fact that, boy, that hurts. But you don't need to. I mean, this is enough to guess that this kid probably has appendicitis. It's the most common thing that'll do this. Fever, some vomiting, and you're going to note that the pain came first, and then he vomited. Remember the pearl of vomiting? He got pain. Usually it's not down in the right lower quadrant. Usually it's central. It's in the epigastric or umbilical area. Moves to the right lower quadrant, and he vomits. And you get that history, and I don't care what else is going on, especially if he's got a temp of 101, this kid goes to the ED and probably has his appendix out before the next sunrise. What's the likely treatment?
Surgery.
Surgery. Good. Now, you got a bunch of other cases in there. If there's something there that piques your interest, we got a lot of time, before I'm supposed to turn you loose. But if you've got other cases that have come up with nausea, vomiting, abdominal pain, or anything else in the whole wide world, let's share them so that if they're helpful, we can talk about them. Let me, think the other useful exercise might be to take one of those cases that I wasn't super fond of and talk about it from the presentation point of view. How about number 12? You got a number 12 that says a 13-year-old female? I just didn't like the questions attached to that. If we read that question, now, everybody got that question. It starts out a 13-year-old female with 1 day. You got that one?
Yeah.
Just read it, and then give it, read it through for a minute, and then I want one person to call the health station and present that case. Somebody want to go for that one? So I pick up the phone and say to you, hello, what do you got?
13-year-old female, conscious and alert. After a school trip yesterday, she's presenting with diarrhea, nausea, vomiting times 1 day. Temperature 99.2, pulse 88, BP 96 over 56, sat at 99%.
How does she look?
Perfect.
Good. All right, that's it. Alert, no apparent distress. Perfect. That's good. Perfect is okay. Perfect is very good. And so I'm going to say to you, yeah, bring her over. Or I might say to you, is she on any meds, or does she have any illnesses? Just to know that this is basically a healthy person as opposed to some kid with some horrible, if you neglected to tell me that she's in a wheelchair from her myasthenia gravis or some ridiculous thing that she needs to go to the ED about. But otherwise healthy person with this presentation, which that'd be the only other thing I would ask you is, do you have any past illness or on any meds? But that's the perfect presentation, because that tells me I can take care of this person. What else did I do?
No, at your facility, what would you do for her when we brought her there?
I'm going to do a little more extensive history, again, to look into whether there's any possible risk factors for anything more serious. But mostly it's knowing that yesterday she was out with a gang and other ones are sick. I think this is a viral or food poisoning illness. both of which can be treated with symptomatic treatment. I'm going to recommend hydration. I'm going to examine her. I'm going to take that history. I'm going to do an exam and make sure the belly is benign and that there's nothing else that I can see wrong with her. She doesn't look sick. And then I'm going to give instructions on how to hydrate her and avoiding milk. And but I'm probably not going to give her Lomodal. What's the other one that we use all the time? Imodium, right? That's what everybody uses. Imodium for diarrhea. I don't use Imodium for most of these cases of diarrhea. Why? Because at least the way I think about it conceptually, if I slow down her diarrhea, that bug or toxin that's causing it is going to stay in there longer, and she's going to be sick longer. She may not have as much diarrhea, but she's going to be sick longer. If I let that process take its course and just fill her up from above, that illness is going to go away faster, because that's a physiologic reaction. She is having diarrhea in reaction to something that she shouldn't have in her. And if it gets it out of her, that's a good thing.
I got a feeling it has something to do with those tuna fish sandwiches that the next kids had.
The next kid.
Case study 13, without refrigerating them.
Yep. Same one.
I'm not sure.
That was a question that you had asked if you were on the rescue about dairy. Would you ask that as a normal follow-up question?
I don't think that it's gonna change. A lot of this stuff is it gonna change what you do? If I know that she's got lactose intolerance, is it gonna mean that I take her to the ED or bring her to the health station? Not gonna matter. So a lot of the way we try to think about how much to do is it gonna change our management? I have trouble at the health station because every person that walks in the door with a sore throat gets swabbed before I see them for strep. And I don't want that, because that's, in the whole framework of healthcare costs, that's crap, right? I mean, I don't know what they charge for, I don't know what they get paid, what anybody pays for a strep thing, but only maybe 10% of those people should have a swab, because once I see them and I go through the history and I find out if they really have a viral illness, because if you don't have a fever and you don't have nausea or vomiting and you don't have pus in your tonsils and you do have a cough, if you meet those 4 criteria, you do not have strep, and there's no sense in swabbing that throat. So I'm trying to not do stuff that's not going to matter in how I manage the case. So if the test or the history or even the exam isn't going to change how I manage that patient, probably I'm better off not. It's just from efficiency standpoint, why spend the time? I think the great question, because we do a lot of stuff because either we were taught to do it wrong, or because it enters our mind and we think, well, it'd be nice to know that. Wouldn't that be interesting to know? But you don't have to worry about things that aren't going to matter in making that decision. Your decision, boy, is ED coming to us. Other questions, concerns, areas of interest?
What were those indicators of strep again?
Fever, nausea, vomiting, pus on the tonsils, all negative, cough positive. Strep throats don't cough. It's very, very rare. So when you combine, because of the rarity, most of them have fevers, most of them have pus on the tonsils, most of them have nausea, vomiting, and very few of them cough. So if you put those 4 together and they're all in the right direction, you can say that's not strep. I don't have to. I check their lymph nodes. That's another little indicator. There are other little indicators, but that's the big 4. No more questions? Too much time off, huh? Thank you all very much for your attention.